There is a smell in the surgical ward that never leaves. It is not the smell of blood, though there is blood. It is not the smell of vinegar, though you use vinegar on everything. It is something underneath those things, something that soaks into the plaster of the walls and the wood of the beds and the linen of the bandages and stays there. You have been here 6 months, and you smell it the moment you wake up each morning, before you even open your eyes, before the bells have finished ringing. It tells you where you are. It tells you what the day will ask of you. This morning, a man on the second bed from the left will decide whether he wants to live. He does not know this yet. He is asleep, the way people sleep when they have been given enough poppy preparation to quiet the worst of the pain, but not enough to stop them waking. His left leg ends just below the knee. It ended there yesterday at the 4th hour, when the chief surgeon placed the bone saw against the tibia and looked at you and said, "Hold him still," and you did. You held him still. The saw took 4 minutes. You know this because you counted. Counting is something you do during the difficult parts of this work, because counting gives the mind somewhere to go that is not where you are. There is a woman in the fever ward who has been here 11 days. She came in with a swelling in her neck the size of a hen's egg. The swelling is smaller now. This is either a good sign or the kind of good sign that turns bad on the 14th day. You do not know yet which kind it is. The physician who oversees the fever ward says the crisis will come before the new moon. He has been right about these things before. He has also been wrong. There is a boy in the eye ward. He is 9 years old, maybe 10. He came in 3 days ago because a hot coal jumped from a brazier and caught him across the right eye. The eye cannot be saved. The chief of the eye ward has explained this to his mother, using a gentleness that you have watched him practice over many years, the particular way he holds his hands, the particular pace of his words. The boy does not know yet. His mother knows. She sits outside the ward entrance each morning when you pass, and she looks at you the way people look when they are hoping that someone walking by will tell them something different from what they have already been told. You do not tell her anything different. You do not have that authority, and even if you did, it would not change the eye. In the bone ward there is a man from the Genoese quarter who fell from scaffolding 3 weeks ago and broke both bones of his left forearm. The bones have been set and splinted with willow wood and linen strips soaked in egg white and flour paste. The standard method, the method that works when it works. His forearm has a slight curve to it that was not there before. He will notice this when the splint comes off. Whether it affects his use of the hand is something you will not know for several more weeks. There is a man who came in yesterday morning with a blade wound across the upper abdomen. He is 31 years old. He is a tanner from the Blackernay district. The wound is 3 inches long and not deep enough to have reached the intestines, which is the line between a wound that is difficult and a wound that is fatal. The physician who assessed him probed it with a clean bronze instrument and declared the intestines intact. You watched the probing. You watched the man's face during the probing. You have started to understand what faces mean in this work. His face meant the physician was right. This is the Pantokrator Xenon, the hospital of the Pantokrator Monastery, in the city of Constantinople, in the year of our Lord 1136. There is no hospital like it in the world. This is Quiet History at Bedtime. If this is your kind of story, a subscribe means everything right now. Every detail in this story comes from the historical record. Just relax and feel free to let this play as you drift off to sleep. Now, let us begin. Your name is not recorded. This is not unusual. The records that survive from this hospital, from this period, do not record the names of the junior surgical staff. They record the names of the chief physicians, the donors, the senior administrators. They record patient numbers and outcomes in the aggregate. You are somewhere inside those numbers, inside those outcomes, doing the work that makes the numbers possible. You are 22 years old. You came to Constantinople from a small town in the theme of Anatolikon, 3 days east of the capital by road, a place that produced grain and wool and, occasionally, young men with enough aptitude and enough ambition to make the journey west toward the city. Your father was a physician of the local kind, the kind who sets bones and lances abscesses and knows which herbs reduce fever, trained not in any formal institution but through apprenticeship, through observation, through the slow accumulation of what works and what does not. He taught you what he knew. What he knew was not nothing, but it was not this. You arrived in Constantinople 4 years ago, at 18, with a letter of introduction from the bishop of your hometown and enough money to last 6 months if you were careful. You were careful. The Pantokrator monastery accepted a small number of students into its medical training program each year, young men identified as having the aptitude for this kind of work. The selection was conducted by the chief physicians, a practical examination that involved assessing a patient's pulse, identifying several medicinal substances by sight and smell, and demonstrating a basic knowledge of Galenic humoral theory. You passed. You know you passed because you were not sent away. No one told you that you had passed. This is consistent with how this institution communicates most things. The training lasted 3 years. You learned anatomy from texts, primarily Galen, some Paul of Aegina, fragments of Arabic medical writing that had been translated into Greek and circulated among the senior physicians. You learned practical surgery by watching, and then by assisting, and then by doing the simpler parts while someone watched you, and then by doing the more complicated parts while someone watched you. And now you are 6 months into your appointment as a junior surgical assistant, and some days no one is watching you at all, and the work still has to be done, and you do it. This is how it works here. Now you must understand what this place is, because there is nothing else like it anywhere in the world, in this year, in this century, in any century that has come before. The Pantokrator Xenon was founded 11 years ago in 1136 by the Emperor John II Komnenos and his wife Erin. The endowment was substantial. The hospital operates on income from imperial estates, from the monastery's own landholdings, from donations made by wealthy Constantinopolitans in exchange for prayers said on their behalf. The money is real. The money is consistent. This is unusual. Most hospitals in the Byzantine world, in the Islamic world, in the Latin West, exist on charity that fluctuates with the generosity of donors and the luck of harvests. This hospital does not fluctuate. It is an institution in the full meaning of that word. There are 5 wards. The surgical ward, where you work, holds 10 beds. The internal medicine ward holds 8. The women's ward holds 12. and is staffed entirely by female physicians and female assistants, which is unusual enough that visitors from the Latin West sometimes refuse to believe it when told. The eye ward holds 6 beds. The fever ward holds 14. The largest ward, because fever is the most common reason people come here. Fever of a dozen different kinds, some of which are the body managing something minor, and some of which are the body failing at something fundamental, and the difference is not always clear from the outside. 50 beds in total. 50 beds does not sound like many. In 1136, in any city in the world, 50 beds dedicated to the care of the sick, staffed by trained physicians working on salary, operating under a written set of rules that specifies everything from how often the linens are to be changed to what the physicians are to be paid and when, is not just unusual, it is extraordinary. The document that governs this hospital, the Tipikon, still exists. You could read it. The regulations are specific, practical, and in several places surprisingly modern in their concern for both the patients and the staff. The staff eat well. The patients eat well. There are regular inspections. There are written records of admissions and discharges and deaths. You are part of this. You are 22 years old, and you are part of something that the rest of the world will not catch up to for several hundred years. You do not think about it in those terms. You think about the man on the second bed from the left, and whether his stump wound is clean this morning. The bells ring prime. First light is coming through the high windows of the surgical ward. The windows set near the ceiling specifically to allow light and air without allowing the patients to see outside, which the chief physician says is better for the mind during recovery. Whether this is true, you do not know. You have never been a patient here. You have never been a patient anywhere. Your body has so far held up to everything you have asked of it, which you understand is luck and not virtue, and you try not to rely on it more than necessary. You take the lamp from its hook by the ward entrance and carry it to the first bed. The first bed holds the tanner from Blackernay, the man with the abdominal wound. He is awake. He watches you come toward him with the particular weariness of someone who has learned that when a person in this place approaches you with a lamp and a careful expression, something is about to happen to your body that you will not enjoy. You tell him you are only checking. This is true. You lift the dressing from the wound with clean hands, using the technique you were taught, touching only the edges of the linen, not the wound itself. The wound is clean. The edges are approximating. There is no heat in the surrounding tissue beyond what is normal for a healing wound. No redness spreading outward. No discharge that indicates the wrong kind of process happening underneath. You replace the dressing. You tell him this is good. He asks when he can go home. You tell him the physician will discuss that with him at the morning round. He nods. He knows that means not yet. The second bed is the man who lost his leg yesterday. His name is Alexios. He is a dock worker from the Contascalian harbor, 43 years old, married, 3 children. You know these things because the admitting physician recorded them and you read the record, and because during the hours before the surgery yesterday when you were preparing him, he told you about his children in the way people tell you things when they are frightened and the telling is something to do with the fear. The wound that necessitated the amputation was not from an accident. It was from a neglected sore. He had a sore on his foot, the kind that begins from a small abrasion, that he had wrapped in cloth and ignored for 6 weeks, because a dock worker who stops working loses his pay, and a dock worker who loses his pay cannot feed 3 children. The sore became infected. The infection moved upward through the tissue of his foot, and then his ankle, and then his lower leg with the particular speed that this kind of infection moves, which is faster than most people expect, faster than Alexios expected, until the skin of his lower leg was black in the way that means the tissue underneath is dead, and the death is still moving, and the only way to stop the death is to cut ahead of it. This is what you did yesterday. You cut ahead of it. He is awake now, watching you approach. His eyes are clear. This is good. Fever would cloud them. You check his forehead with the back of your hand. Warm, but not the wrong kind of warm. You lift the dressing from the stump. The wound is closed with the suture technique the chief surgeon prefers, a continuous suture in waxed linen thread. The knots placed at intervals to allow drainage if drainage becomes necessary. The wound surface is clean. There is a small amount of seepage at one end, which you note. You replace the dressing with clean linen soaked in the honey preparation, the one made with thyme honey from the monastery's own hives, because the chief surgeon believes, on the basis of 40 years of observation, that honey suppresses the wrong kind of healing and promotes the right kind, and his observation has been consistent enough that you have stopped questioning it and started trusting it. You do not always understand why a thing works. You understand that this thing works. Alexios watches you work. He asks, very quietly, whether he is going to die. You have been asked this question before. You will be asked it again. There is no training in the Typikon or in the medical texts for how to answer it. You have watched the senior physicians answer it, each in their own way. Some deflect, some give probabilities. One of the older physicians, a man named Konstantinos, who has been working in this hospital since the founding, answers it the same way every time. He says he does not know, but that the body is working, and that working is what you need it to do right now. You tell Alexios the same thing. The body is working, and that is what you need it to do right now. He nods. You move to the 3rd bed. The 3rd bed holds a monk from a monastery in the Samathia district who came in 4 days ago with a growth in his lower abdomen that the chief physician palpated and diagnosed and declined to operate on. The growth is the kind that cannot be cut without killing the patient before the cutting is finished. There is nothing in the pharmacopoeia, in Galen, in the Arabic texts, in any text available in the hospital library, that addresses what is happening inside this man's body in a way that will stop it. What the hospital can do is manage his pain. What the hospital can do is keep him comfortable and fed, and in a clean bed with clean linens, and attended by people who know what they are watching as it progresses. He is sleeping now. His breathing is regular and slow. You stand at the foot of his bed for a moment longer than is strictly necessary for the morning check. This is something you have started doing in the 6 months of this appointment. Standing a moment longer at the beds where the situation is what it is, and what it is cannot be changed. You are not sure why you do this. It is not prayer exactly. It is something more like acknowledgement. This person is here. You are here. The morning is the same morning for both of you. You move on. The ward has 10 beds. You check all 10. By the time you finish, The light through the high windows has strengthened to the point where you no longer need the lamp. You hang it back on its hook. The chief surgeon arrives at the 7th hour every morning, after the monastic offices of Lauds and Prime, after his own breakfast. His name is Michael. He has been the chief of the surgical ward for 9 years. He is 51 years old, compact, precise in movement, with the economy that develops in people who have spent decades performing actions that require both speed and accuracy, and have learned that any motion that is not necessary is a motion that takes time you may not have. He is also, occasionally, genuinely frightening. Not through anger. He rarely raises his voice. He is frightening through the precision of his observations, the way he notices everything you have done and everything you have failed to do, and the way he distinguishes between these two categories with an accuracy that you have not yet learned to anticipate. In your first month in the surgical ward, he reviewed your morning checks 3 times and found errors each time. Not dangerous errors, small errors, the kind that become dangerous errors if they are not corrected before they become habits. He corrected them before they became habits. You are grateful for this, in the way you are grateful for things that are painful at the time and useful afterward. He walks through the ward entrance now, followed by the ward's other junior assistant, a young man named Euthemios, who has been here 4 months longer than you and has developed, in those 4 months, a particular competence with the suturing of wounds that the chief surgeon has noticed, and occasionally compliments in the oblique way he compliments things, which is by assigning more of those tasks to Euthemios without explanation. Michael goes to the first bed. You follow at the correct distance, which you learned by trial and the correction of error. He lifts the dressing from the tanner's wound himself, examines it, replaces it. He says nothing. This means it is what he expected, which means it is acceptable. Acceptable is good. Acceptable means the work of yesterday is holding. He moves to Alexios. He examines the stump wound with an attention that you find difficult to watch and difficult to look away from simultaneously. He probes the edges of the wound with a clean instrument. He examines the seepage you noted. He is quiet for a long time. Then he says that the seepage wants watching. He says this to you specifically, which means you are responsible for watching it, which means every hour today, not every 2 hours. Every hour, you will lift that dressing and look and replace it and record what you see. You say yes. He moves on. At the monk's bed he stops. He does not examine the wound because there is no wound to examine. He checks the pulse at the wrist, the standard Galenic method, the 4 qualities of pulse that indicate the state of the vital spirit. He sets the monk's hand back on the blanket with a care that is different from his clinical precision, a care that belongs to a different part of him than the surgeon. He tells Euthemios to increase the poppy preparation at the next dosing. He moves on. When the round is finished, he stands at the ward entrance and tells you both what the day requires. There are 2 minor procedures this afternoon, both lancing of abscesses. Straightforward, Euthemios will assist. There is 1 consultation from the internal medicine ward, a patient with a swelling that may or may not require surgical intervention. You will attend the consultation and give your assessment. The seepage on bed 2 wants watching every hour. The monk's family has asked to visit this afternoon, and this is approved. He leaves. You stand in the ward in the strengthening morning light. The smell is there, underneath everything, the way it always is. You stopped noticing it for a while, sometime in the second month, and then you started noticing it again, and now you think you will notice it for as long as you work in this place, which may be a long time or may not be, because nothing in this city in this year is certain. And the city itself is a thing that has survived by being less certain than it appears from the outside. But that is later. That is politics and empire and the movements of armies in distant provinces. Right now there is a stump wound on the second bed that wants watching every hour. You take out the small wax tablet you carry in the fold of your belt. The one you use for notes that are not important enough for the formal record, but important enough to remember, and you mark the time of the first check. The morning is beginning. You begin with it. The consultation from the internal medicine ward happens at the 3rd hour. The patient is a merchant, 56 years old. A man who trades in silk from the eastern provinces and has the particular kind of body that develops in men who have eaten well for several decades and moved very little. He has a swelling on the left side of his neck that appeared 3 weeks ago and has grown since its appearance. The internal medicine physician, a careful man named Stephanos, who has been at this hospital for 6 years, requested the surgical consultation because the swelling has the firmness and the fixed quality that suggests it is not simply an inflamed gland which would soften and move, but something more structured, which may or may not be something that can be addressed surgically. You examine it with clean hands, as you were taught. The swelling is approximately the size of a large olive. It is firm. It does not move freely when you press it sideways. The skin over it is not hot, not red, not showing the surface signs of acute infection. The merchant watches your face while you examine his neck with the watchfulness of a man who has spent his life reading other people's expressions for information about prices and intentions. You keep your face neutral. This is something Michael has taught you, though not in words. He taught it by example, by the steadiness of his expression during examinations, a steadiness that is not coldness but is discipline, the discipline of not allowing your face to add information to a situation that already has enough uncertainty in it. You tell the merchant you would like to ask him some questions. He says yes. You ask how long the swelling has been there. 3 weeks, he says. You ask if he has lost weight recently without intending to. He pauses. He says perhaps a little. He says he has not been as hungry as usual. You ask if he has had fevers in the evening that clear by morning. He looks at you differently now. He says yes. He asks how you knew that. You tell him it is part of the pattern. You do not tell him what the pattern suggests. You do not have that authority, and even if you did, you are not yet certain enough in your own assessment to speak it aloud. You tell him you will discuss with the senior physician and return. You return to Stephanos. You give your assessment. The swelling has the character of something arising from the lymphatic system, you say, using the term as Galen uses it, as the texts use it, though the understanding of what the lymphatic system is and what it does is in 1136 still partial, still working from a framework that is more right than wrong in some places and more wrong than right in others. The evening fevers, the lack of appetite, the weight loss, the fixed, firm quality of the mass. You have seen nothing like this in the surgical ward. because there is nothing in the surgical ward to be done about it. But you have read about it. You have read Paul of Aegina's description of glandular swellings, and you have read the section in the Arabic text translated for the hospital library that addresses what the Arab physicians call diseases of the lymph nodes. Stephanos listens. He nods. He says he has reached the same assessment. He asks what you would recommend. This is unusual. Junior assistants are not typically asked for recommendations by senior physicians. You understand that he is asking not because your recommendation will determine the treatment, but because he is a teacher as well as a physician, and this is how he teaches, by asking, by making you articulate what you know, and discover in the articulation where your knowledge ends. You say you would not recommend surgery. The location, the character, the systemic symptoms suggest this is not a localized problem that can be excised. Surgery on a mass of this kind in this location carries serious risks to the vessels of the neck, and even if the mass were successfully removed, the systemic nature of the disease suggests it would return. You say what you can recommend is what the hospital already provides: clean air, good food, management of the evening fevers with the standard preparations, keeping the man comfortable and observed. Stephanos says yes. He says you have read more carefully than he expected of someone 6 months into an appointment. You say you read because the nights are long when you are on call and the ward is quiet and there is light enough from the lamp to read by, and the library has more texts than you will finish in the years you are here. He looks at you for a moment in the way people look when they are deciding whether something is modesty or simple truth. He nods and turns to write his notes. You return to the surgical ward and check the seepage on Alexios's wound. It is the same as this morning, not worse. You note the time on your wax tablet. The afternoon brings the 2 abscess lancings that Michael assigned to Euthemios. You watch. This is part of the work that is never formally described in the Typicon or in any training document, but is understood by everyone who works here. You watch everything. You watch when you are not assisting, when you are not the one being watched, when there is nothing that requires your hands. You watch the way the more experienced people do things, the small choices they make about angle and pressure and sequence, and you file those choices somewhere that is not quite memory and not quite instinct, but something between the two that you will draw on later in situations where there is no time to think, and the hands have to know what to do without being told. The first abscess is straightforward. A young woman, 19, from the Fanar district, a seamstress with an abscess on the left forearm that has been there for 10 days and is now fluctuant, which is the word for the quality an abscess develops when it is ready to be opened, when the pressure inside it has built to the point where drainage is both possible and necessary. Euthemios locates the point of greatest fluctuance with the pad of his finger, stabilizes the arm, and makes the incision with a single controlled motion, a motion you recognize as something Michael has demonstrated and Euthemios has practiced until it is no longer demonstration but action. The drainage is immediate and substantial. The seamstress makes a sound, not a scream, a sound of relief, because this is what it feels like from the inside when an abscess is opened, the sudden release of a pressure that has been building for days, the shift from a constant painful fullness to a sharp moment, and then the diminishment of both. Euthemios irrigates the cavity with vinegar solution, the standard wound irrigation, vinegar in water in the proportion that the chief surgeon specifies. He packs the wound loosely with clean linen to allow continued drainage. He dresses it. He instructs the ward assistant on the dressing change schedule. The second abscess is more complicated. The patient is a man of approximately 40 who arrived this morning, referred from the monastery's outer medical dispensary, the place where people who cannot afford the full hospital admission come for basic treatment. He has an abscess on his lower back in the deep tissue, which has been there long enough that the outer skin is intact but the infection beneath is extensive. This kind of abscess is harder. The location makes access difficult. The depth means the incision must be long enough and in exactly the right place to reach the deepest part of the cavity, or drainage will be incomplete and the abscess will reform. Euthemios studies the location. He palpates carefully. He looks at you, not for confirmation, but in the way that people look when they are thinking out loud with their hands and want a second pair of eyes on the same surface. You look. You feel the boundary of the fluctuance with your own finger. You indicate where you think the deepest point is. Euthemios nods. It matches what he found. He makes the incision. It is slightly short of where it needs to be. The drainage begins but is incomplete. You can see from the residual swelling after the initial flow that the cavity extends further than the incision reached. Euthemios sees it too. He is quiet for a moment, the particular quiet of someone who has made an error and is assessing what the error requires. He extends the incision. The drainage completes. He irrigates, packs, dresses. His hands are steady throughout. His face does not change. Afterward, when the patient has been moved to the recovery area and Euthemios is washing his hands at the basin, you do not comment on the error. This is not because it was not an error. It was. It is because the error was recognized, assessed, and corrected, and the correction was made with the same competence that would have been there from the beginning if the first assessment had been different. The patient is not harmed. The lesson is already inside Euthemios's hands. Some things do not need to be said. You check Alexios at the 4th hour. The seepage is slightly less than before. You note this carefully. Less seepage means either the wound is beginning to close properly or the pathway for drainage is beginning to block, and blocked drainage is worse than seepage. So you lift the dressing more carefully than usual and examine the wound surface and the edges and determine that the reduction is from closing, not from blocking. The edges are approximating well. The honey surface of the wound has the color and texture that Michael describes as correct. You replace the dressing. Alexios is awake. He has been awake most of the day, which is better than sleeping too deeply, because a man who sleeps too deeply in this ward is often a man whose body has stopped fighting. He asks you again whether he is going to die. You tell him again that his body is working. He says he knows that. He says what he is asking is whether you think he will go home to his children. You stand at his bedside for a moment. Outside the high windows, the light is beginning to shift toward afternoon. Somewhere in the city, very distantly, you can hear the sound of the harbor, the creak and noise of the Cantoskalion where Alexios worked, where he will not be working for a long time, where he may not be able to work in the same way again, because a man who works a dock works with his whole body, and Alexios's body has changed in a way that will require him to learn what it can still do. You tell him that the wound is cleaner than it was this morning. You tell him that this is the direction you need it to go. You tell him that his children will be told he is working in that direction. He looks at you. He says, "Thank you." This is the part of the work that no text addresses. Not Galen, not Paul of Aegina, not the Arabic translations in the library. The part where the person in the bed looks at you and what they need from you is not your hands, but something that does not have a name in the medical literature, something that passes between one person and another person in a moment when the gap between them is very small because both of them understand that what is happening is serious and real. You move to the next bed. The monk's family comes at the 6th hour. There are 3 of them, his brother, a man of similar age, and 2 younger people who may be the brother's children. They are admitted in the approved manner, checked at the ward entrance by the ward orderly, reminded of the visiting rules, times and conduct, and what they are and are not permitted to bring. They sit at the monk's bedside. You go about your work on the other side of the ward, giving them what distance the ward's dimensions allow, which is not very much, but is something. You can hear them talking, the low, even sound of a conversation that has moved past what is happening to what has already happened. The shared history of people who have known each other for many years and are now sitting in a room where one of them is at the end of theirs. The monk wakes during the visit. You see him wake. You see his eyes find his brother's face. You look away. Some things are not for the physician's eyes, even the physician's assistant's eyes. The typicon specifies the visiting rules for good clinical reasons, reasons about rest and infection and the management of the ward's routine. But the typicon was written by people who also understood that a person dying in a hospital bed is still a person, still connected to everything outside these walls, and that the connection matters in ways that cannot be measured by the methods the hospital uses to measure other things. By the 7th hour, the family has gone. The monk is asleep again. You check the seepage on Alexios one more time before the evening meal is brought to the ward. Still less than the afternoon check. You note it on your tablet. You note it in the formal record. You tell Euthemios when you pass him in the ward corridor, because if something changes in the night and you are not the one on call, Euthemios needs to know what the baseline is. Euthemios nods. He asks about your assessment from the consultation with Stephanos. You tell him. He thinks about it. He says he has seen one case of what you are describing in his 4th month here, a young woman, which was unusual for the condition in his understanding, and that the outcome was what you would expect. He says it quickly and without elaboration. The way people at this hospital talk about the outcomes that are what you would expect. Matter of fact, not cold. Just the language that develops in people who deal with these things often enough to need a way to say them efficiently. You ask how long it took. He says 4 months from the time she arrived. The evening meal arrives for the ward at the 8th hour, brought by the monastery kitchens in the large clay vessels that keep the food warm during transport. Broth for the patients who cannot eat solid food. Bread and cooked grain and legumes for those who can. A portion of the monastery's own fish preserves on certain days. The quality of the food here is specified in the typicon, and the specification is genuinely generous by the standards of 1136, by the standards of what most of these patients would eat at home. This is deliberate. The founders understood, in practical if not biochemical terms, that a body healing from illness or injury requires adequate nourishment. that the resources the body needs to repair itself have to come from somewhere, and that the somewhere had to be the food. You eat your own meal in the staff area at the end of the ward, the small room with the table and the 2 benches where the junior staff eat and where the medical library's overflow volumes are kept on a shelf that is always slightly too full and from which books occasionally slide onto the bench below. Euthemios is on call tonight. You are on call tomorrow night. Before you leave the ward for the evening, you check Alexios one more time. He is eating, or trying to eat, holding the bread awkwardly in hands that are tired from a day of not moving enough. You adjust his blanket. You check his forehead. Cool. The correct kind of cool. The cool of a body that is not fighting a systemic infection. Just the local fight of a wound trying to close. You tell him good night. He says good night. You take your lamp and walk out through the ward entrance and into the corridor of the Pantokrator Xenon, and the sound of the ward diminishes behind you, and ahead of you are the monastery's stone corridors, and the smell of the evening, and the low bells of vespers beginning somewhere in the church above. Tomorrow there will be more. There is always more. But tonight the ward is Euthemios's responsibility, and the monk is sleeping, and Alexios is eating bread, and somewhere in the Blakerne district 3 children are waiting for news that their father's body is working, and the body working is what the next hours require. You walk toward the light. The corridor connects the surgical ward to the main body of the monastery, a stone passage that runs along the northern side of the complex, open at intervals to a courtyard where a fig tree grows that is older than the hospital by several decades. The tree is already in leaf, the broad leaves catching the last of the day's light. You pass it every evening. You have started to use it as a kind of marker, the way the tree looks telling you something about what the season is doing, the way time moves differently here than it did at home, where the seasons were marked by agricultural rhythms, by planting and harvest and the particular quality of the cold coming off the mountains in October. Here the seasons are marked by disease. Winter brings the fever ward to capacity, always. The cold that moves through the city's poorer districts, the overcrowded insulae near the harbors where the population density and the inadequate heating and the shared water sources create conditions for the spread of respiratory illness, fills the fever ward from December through February with a consistency that the senior physicians can predict within a few weeks. They prepare for it. The pharmacopoeia is restocked in November. Additional bedding is arranged. The admissions physician at the outer gate is briefed on the differential criteria, because in winter the question of who gets a bed and who is sent home with instructions is a more difficult question than in other seasons when there is space. Spring brings wound infections. This surprises you when you first understand the pattern, but the explanation is straightforward once you see it. Spring is when construction work resumes after the winter, when the harbor labor intensifies as the shipping season opens, when agricultural work begins in the fields outside the walls. More people doing more physical work means more injuries. More injuries means more wounds. More wounds, improperly treated at home or treated too late, means more of what you are watching on Alexios's stump. Summer brings the gastrointestinal cases, the contaminated water cases, the children especially, the children from the neighborhoods where the water supply is least reliable, and the summer heat accelerates what contaminated water does. Autumn is the calmest season. The physicians call it the healthy season, though in 40 years of the hospital's future existence, there will be no season that is uniformly healthy, only seasons that are less catastrophically otherwise. You know some of this from the records. The admissions records go back 11 years to the founding, and they are detailed enough that patterns emerge from them if you read them carefully and think about what you are reading. You have read them. You read them in the first month when everything was new and you were trying to understand the institution you had entered, and the records told you something the formal training had not, which was that this place existed in a relationship with the city outside it, that what happened in the streets and the harbors and the markets of Constantinople arrived here eventually in the bodies of the people who worked and lived in those streets and harbors and markets, and that to understand what you were treating you had to understand where it came from. Michael has never said this to you directly, but when you look at his practice, the questions he asks patients during the initial examination, the attention he pays to where a person lives and what they do and how they live when they are not sick, you understand that he knows it in a way that is deeper than anything that could be said. You stop at the entrance to the library room. The library occupies a small chamber off the main corridor, 2 shelves of codices and several rolled older documents in protective casings. The collection built over 11 years from donations by physicians, from purchases made by the hospital administration, from copies made by the monks of texts borrowed from larger collections in the city. It is not the largest medical library in Constantinople. The libraries attached to the larger monasteries and the imperial library contain more. But it is here, in the building where you work, accessible at any hour, and that proximity is worth more than size. You take a lamp from the bracket outside the room and carry it in. The text you have been working through for the past 3 weeks is Paul of Aegine's Surgical Compendium, the 7th book, which deals specifically with operative procedures. Paul was working in the 7th century, 500 years before your time, and his work represents the point at which Greek medical knowledge and earlier Roman practice and some of the emerging Arabic synthesis were all in contact and beginning to combine. The 7th book covers wound treatment, fractures, dislocations, amputations. You have read the amputation section twice since yesterday. You read it again now. The language is technical and precise and occasionally contradictory, the way old texts are contradictory when the knowledge behind them was being assembled from multiple sources that did not always agree with each other. Paul describes 2 techniques for stump wound closure after amputation. The first, which Michael used yesterday, involves the continuous suture. The second describes a method of leaving the wound partially open to allow drainage before closure, a method Paul attributes to earlier sources he does not name. Michael's method is faster. The second method may be safer in cases where the tissue quality is uncertain. You sit with this for a while. This is not a question you can resolve tonight, or perhaps ever, with the tools available to you. The comparison would require cases that are comparable in their specifics: amputation level, tissue condition, patient age, and general health, conducted under controlled conditions, and the results followed carefully over weeks. What you have instead are Paul's descriptions, Michael's experience, the cases you have seen since you arrived. It is not enough to draw conclusions from. It is enough to keep the question open. You close the codex. You carry the lamp back to the bracket. The bells for Compline are beginning. The late evening office, the last formal prayers of the monastic day before the great silence descends over the monastery and everything becomes quieter. The particular silence of a large institution settling into its nighttime state, the sounds diminishing one by one, until what remains is only the essential sounds, the small noises of a building breathing. From somewhere in the surgical ward, if you stand still in the corridor, you can just hear the low sound of the ward at night. Not voices, not activity, just the ambient sound of 10 people breathing in the same room, the small shifts and sounds of sleep and near sleep, the occasional word or sound from someone whose body is working through something in the night. You stand still for a moment. You listen. Then you continue toward the staff quarters, carrying your lamp, your wax tablet, the accumulated observations of a day that is now ending. Tomorrow you will be back before the prime bells. Tomorrow the seepage on bed 2 will need checking at first light. Tomorrow there is a city outside these walls, doing everything a city does, and some of what it does will arrive here in the bodies of the people who live in it, and you will be here to meet them. You walk toward the light. The next morning begins the same way every morning begins. The smell finds you before you open your eyes. You are on the pallet in the staff quarters, a narrow room with 3 pallets and a window that faces east, and the light through the window is the particular gray that precedes sunrise, the color of stone in the moment before the sun touches it. You have been awake for several minutes already. This is normal. You have not slept past the first sign of light since you began this work, because the body that is responsible for other bodies develops its own early warning system, a sensitivity to time that does not require a bell. You dress in the dark. You carry your lamp to the surgical ward. Euthemios meets you at the ward entrance, the handoff between the night's watch and the morning's work, the moment where what he knows becomes what you know. His face is tired in the specific way of someone who has been awake through the difficult hours between the 2nd and 4th watch, the hours when the body's own rhythms are at their lowest, when patients who are going to worsen tend to worsen and the ward feels different from how it feels in daylight. He tells you the monk's breathing changed at the 3rd watch. He tells you Michael was notified and came to the ward and adjusted the poppy preparation dosing. He tells you the breathing stabilized. He tells you the monk is still alive. He tells you Alexios had a fever spike at the 2nd watch that broke by the 4th. He tells you the seepage on the stump wound increased during the fever and then decreased again as the fever came down. He tells you he changed the dressing twice and irrigated once, and that the wound, in his judgment, looks the same as it did yesterday morning, not worse, possibly marginally better. You note all of this on your tablet. Euthemios goes to sleep. You begin the morning check. The monk's breathing is slower than it was 2 days ago, not labored. Slow in the way that deep things move slowly, the way a river moves in its widest part. His color is the color of old wax. You check his pulse the way Michael does, the 4 fingers at the wrist, counting the rhythm and assessing the quality. The pulse is weak but regular. This is what it has been. Regular is what you need. You move to Alexios. His eyes are open. He looks at you the way he has started looking at you, with a recognition that has developed over these days into something that is not friendship exactly, but is in the same territory. The particular connection that forms between a person who is ill and the person who checks on them every hour, who knows their wound better than they know it themselves. You lift the dressing. Euthemios was right. The wound looks the same. The honey surface is intact. The suture edges are approximating. The small amount of seepage remaining is the right color, the clear amber color that indicates the wound is doing its own work rather than fighting an infection it is losing. You tell Alexios his wound looks good this morning. He says good is a word he has not heard enough of recently. You replace the dressing. You finish the ward check and stand at the entrance writing your notes when Michael arrives at the 7th hour. He does the morning round with the same precision he always does, and at the monk's bed he stands longer than he stood yesterday. And at Alexios's bed he examines the wound himself and says nothing, which means it is what he expected. At the end of the round, he tells you there is a new admission coming this morning. He says the outer dispensary sent a notification last night. A woman, approximately 30 years old, admitted overnight to the women's ward with injuries from a fall. The injuries include a suspected fracture of the right wrist and lacerations to the face and hands. He says the women's ward physician has requested a surgical consultation on the wrist. He says you will conduct the consultation. Not assist, conduct. You understand what this means. You understand it the same way you understood when Euthemios was assigned the abscess lancings yesterday. The same way the hospital communicates everything important, not by announcement, but by assignment, by the gradual extension of what you are asked to do until you are doing things you were not doing before and could not have done when you arrived. You say yes. The consultation is at the 3rd hour. The women's ward is on the south side of the complex, separated from the surgical ward by the central corridor and the dispensary room where medications are prepared and distributed. You have been in the women's ward before during your training period, but not often and not recently. The ward has its own rhythms, its own staff, its own atmosphere that is different from the surgical ward in ways that are difficult to name precisely. The physician who oversees it is a woman named Anna. This fact, in 1136 Constantinople, in this hospital, is unremarkable. The Typicon specifies that the women's ward is to be staffed by female physicians. This is practical. Female patients in this era, in this culture, are more likely to seek and accept treatment when the physician is female, and the hospital's founders understood that a hospital whose patients do not come to it has failed its purpose regardless of the quality of its medicine. Anna has been here since the founding. She trained at the medical school attached to the Mangana Monastery, one of the few institutions in Constantinople that accepted female students in the 12th century, and she has been practicing for longer than you have been alive. She meets you at the ward entrance. She tells you about the patient with an efficiency that you recognize as the language of someone who has been doing this for a long time and does not need to frame things for an audience. Just convey them accurately and move. The patient's name is Zoe. She is 28 years old. She is from the Fenar district. She came in last night with a wrist that shows the deformity characteristic of a displaced fracture of the distal radius, the bone you know from Paul of Aegina's descriptions, the break that happens when a person falls and puts their hand out to catch themselves. She also has lacerations on her palms and face, the lacerations you get when a fall is sudden and the hands and face meet a surface before the rest of the body understands what is happening. Anna says the lacerations are already cleaned and dressed. She says the wrist requires your assessment for reduction. Reduction is the word for putting a displaced fracture back into alignment. The process of moving the broken bone ends back to their correct position so the bone can heal straight rather than healed wrong. It is one of the oldest surgical procedures described in Hippocrates, described in every major text since, and in 1136 it is done without any anesthetic beyond poppy preparation and wine, by hand, by feel, by the judgment of the person doing it about when the bones are aligned correctly. You have assisted with 2 reductions. You have not conducted one. You follow Anna into the ward. Zoe is sitting on her bed. She is holding her right wrist with her left hand, the careful hold of someone who has learned through the night that stillness is the only thing that reliably reduces the pain. Her face has the cleaned marks of the lacerations, pink lines across her left cheekbone and jaw, not deep, well cleaned. Her eyes are steady. She is frightened. You can see that, but she is managing the fear in the way some people manage it, by holding very still and watching everything with full attention. You introduce yourself. You tell her you are here to look at her wrist and discuss what needs to happen. She nods. You examine the wrist. The deformity is visible even without touching it. The classic displacement described in every text. The distal fragment shifted backward and slightly to the side. The wrist having the appearance that some texts describe as a dinner fork. The angle wrong in a way that is obvious once you know what you are looking at. You palpate carefully. She hisses when you reach the fracture site. You note the location of the tenderness, the quality of the displacement, the circulation in the fingers distal to the fracture, the sensation in the fingertips when you ask her to tell you if she feels your touch. She feels your touch in all fingers. This is important. It means the displacement has not compromised the nerves or vessels to the hand. It means reduction can proceed. You explain to her what is going to happen. You explain this in the way you have watched Michael explain procedures, not abbreviated, not assuming she understands things she has no reason to understand, but not overlong either, just accurate and clear and delivered at a pace that allows her to follow it. You tell her the bone is displaced. You tell her it needs to be moved back to its correct position. You tell her you will give her preparation for the pain before you begin, and that the procedure itself is brief, a matter of minutes, and that it will hurt during the reduction and then significantly less afterward. You tell her that once the bone is in position it will be splinted to hold it there while it heals, and that healing takes several weeks. She asks if she will be able to use her hand afterward. You tell her yes. You tell her the displacement is not severe enough to have compromised the joint, and that properly reduced and properly splinted the hand should heal with full or near full function. She says all right. The poppy preparation is brought. You wait the appropriate interval for it to take effect. You have learned this interval, the difference between the interval that is long enough and the interval that is not, by watching what happens when the reduction is attempted before the preparation has had time to work, which is not something you watched happen often, because Michael does not allow it to happen often, but once is enough to understand the difference. Then you reduce the fracture. It takes 3 attempts. The first attempt moves the fragment but does not seat it. You can feel the bone moving under your hands, the strange mechanical sensation of bone under skin, and you can feel when it is not in the right place because the angle is still wrong and the resistance tells you the surfaces are not mating. You release, reassess, try again. The second attempt gets closer. The third attempt produces the sensation that every text describes but that no text can really convey. The particular feel of bone, ends finding each other across the gap of displacement and settling, the tiny shift of alignment, and then the deformity is gone and the wrist looks like a wrist again. Zoe is breathing hard. Her left hand is gripping the edge of the bed. You tell her it is done. You tell her the bone is back in position. You tell her the hardest part is over. She does not speak for a moment. Then she asks if you are sure it is in the right place. You tell her you are sure. Anna hands you the splinting materials, the willow slats and the linen strips soaked in the binding paste, and you apply the splint with the technique you know, checking the alignment one more time as you work, making sure the paste-soaked linen holds the position the reduction achieved. You check the circulation in the fingers again when the splint is applied. Still good. The fingertips are warm and the sensation is intact. You tell Zoe the splint will be checked tomorrow, and that she should tell the ward staff immediately if the fingers become numb or cold, or if the pain increases significantly rather than decreasing. She says she understands. You tell her she did very well. This is not something Michael says. You are not sure where it comes from in you. But Zoe nods when you say it, and something in her face changes slightly. The particular shift that happens in people's faces when they have been holding something very tightly and are given a small permission to release it. You return to the surgical ward. Michael is at the preparation table, reviewing something in the admissions record. You give him your report on the reduction, the displacement, the 3 attempts, the final position, the splinting, the circulation check. He listens without interrupting. When you finish, he says good and goes back to the record. This is high praise. The afternoon brings a new admission to the surgical ward. A man, 61 years old, referred from the outer dispensary with what the admitting note describes as a growth in the right groin. He arrives walking, though with the slightly tilted posture of a man who has been adjusting his gait for some time to avoid aggravating something. He is a baker by trade. He has thick forearms and the particular look of someone who works with his body, who is more comfortable with physical effort than with sitting still, and who is therefore less comfortable than usual now when his body is doing something he cannot work his way out of. You examine the groin. The growth is what is called in the texts a hernia, the protrusion of abdominal contents through a weakness in the abdominal wall, a common condition in men who do heavy lifting over many years, the repetitive pressure of lifting gradually overwhelming the structural integrity of the wall until a gap opens and tissue pushes through. The baker's hernia is large, the size of a plum, and it has been there long enough that the tissue feels soft and reducible, meaning you can push it back through the gap, which you demonstrate with gentle pressure while he lies on the examination table, and it goes back where it belongs. This is temporary. Every time he stands, it will come back through. You explain this to him. You explain that the hernia itself is the symptom, not the problem. The problem is the weakness in the wall. The only way to address the problem is surgery, a procedure that involves opening the area, reducing the herniated tissue, and reinforcing the wall with sutures. This procedure is described in Paul of Aegina. Michael has performed it multiple times. You have assisted with one. The baker asks if it is necessary. He asks this the way people ask when they have been managing something for a long time and have developed a relationship with the managing that feels more familiar than the prospect of stopping managing it. You tell him it is not immediately necessary. You tell him the risk is that a hernia left untreated can become strangulated, the herniated tissue becoming trapped and losing its blood supply. And a strangulated hernia is a surgical emergency, and surgical emergencies have worse outcomes than planned procedures. He thinks about this. He asks when. You tell him that is a conversation for the chief surgeon, and that you will arrange for Michael to see him tomorrow morning. He nods. He has the look of a man who has made a decision but not yet admitted to himself that he has made it. You make the note in the admissions record and arrange the bed at the end of the ward, the bed that was empty this morning and is now this man's place in the world for whatever duration his treatment requires. The ward orderly brings bedding. The kitchen notification for the evening meal is updated to add one. This is how a hospital works. One person at a time, one bed at a time, one decision at a time about what the body needs and what the hospital can provide, and how those two things can be made to meet. By the 6th hour, the ward has found its afternoon rhythm, the particular quiet of a ward in the hours between the midday round and the evening round, when the patients who can sleep are sleeping and the patients who cannot are in the state between sleep and waking that is its own kind of rest. You check Alexios. The wound is unchanged. The seepage is minimal. His color is better than yesterday. You stand at the foot of his bed. He is asleep, finally. Deeply asleep in the way he has not been sleeping since he arrived, the sleep of a body that has been fighting hard and is beginning to believe it is winning. You let him sleep. You do not check the dressing. The hour can wait. You sit on the stool at the end of the ward instead. This is not something you would do if Michael were here. Michael does not sit. Michael moves, examines, writes, considers, moves again. In his presence, the ward operates at the pace his presence sets, which is efficient and purposeful, and leaves no room for the kind of stillness you are sitting in now. But Michael is not here. The afternoon round is finished. The evening round is 2 hours away. The ward is quiet, and the patients who can sleep are sleeping, and there is, for this brief interval, nothing that requires your hands. You sit. You think about the wrist reduction. 3 attempts. 2 would have been better. 1 would have been ideal. You run through what happened in the second attempt, the moment where you felt the fragment moving and misjudged the angle, the small error of pressure direction that sent it slightly past the correct position rather than into it. In the text, Paul of Aegina describes the correct vector of force for this type of displacement with a precision that reads clearly on the page and translates into the hands only imperfectly, because the page does not have the resistance of living tissue, does not have the variation between one person's wrist and another's, does not have the adrenaline of being watched by a patient who is in pain and trusting you. You think about what you would do differently. You would change the angle of your initial grip slightly. You would use more traction before attempting the rotation. You would not rush the transition between the two movements. This is the work of the afternoon, the work that does not appear in the admissions record or the treatment notes, the private reckoning with what happened and what it would take to make it go better next time. Michael does this too, you think, though you have never seen it. because Michael's private reckonings happen somewhere you are not. But you can see the outcomes of them in the way his technique has the quality of something that has been thought about many times, refined over many years, until the thinking is no longer visible behind the action. You will be 40 before this work looks like that. If you are still doing this work at 40, Constantinople in the year 1136 is a city of approximately 400,000 people, the largest city in the Christian world, the largest city west of the Islamic caliphates. It has been the capital of what it still calls the Roman Empire for over 800 years, the direct continuation of the eastern half of the empire that the western half lost in 476. The city's walls, the Theodosian walls built in the 5th century, have never been breached. The city's position at the junction of Europe and Asia, commanding the Bosphorus Strait, makes it simultaneously the most defensible city in the known world and the most strategically valuable. And these two facts have been in tension for as long as the city has existed. The emperor now is John II Comnenus, the man who founded this hospital, and he is in the east this year, conducting the military campaigns against the Danishmend Turks and the Crusader states in Antioch that have occupied the last decade of his reign. He is a capable general by all accounts. He is also the man who signed the Typicon that specifies how often the linens in this ward are to be changed, which tells you something about the particular quality of his attention to the world. Whether he will return from the east is the question the city always holds about its emperors when they campaign. Campaigns are uncertain. The body of an emperor is as mortal as the body of a dockworker in the end. You know this from the history you read, the long list of emperors who left Constantinople and did not come back, the campaigns that turned, the sieges that failed, the arrows that found the wrong person. You try not to think about this too much. The city is the city. You are here because of what the city makes possible. The accumulation of resources and knowledge and institutional will that produced this hospital, this library, this particular afternoon in which you sit on a stool in a quiet ward and think about wrist reductions. You could not be doing this in Anatolia. You could not be doing this in most of the world as it exists in 1136. You are here. You are learning. That is what the afternoon is for. The baker stirs on his bed at the end of the ward. He is lying on his back, looking at the ceiling with the expression of a man who has made a decision and is now in the process of accepting it. You have seen this expression before. It appears on the faces of people who came in believing that the hospital might offer them some alternative to the thing they feared and have concluded, in the hours since admission, that the hospital is in fact going to do the thing they feared, and that the thing they feared is also the thing that needs to happen. He catches you looking at him. He asks if it is a difficult surgery. You tell him the truth, which is that it is not among the most difficult that this ward performs. You tell him that Michael has done many of them. You tell him that the risk is real but manageable, and that the risk of not doing it is also real and less manageable than people assume until the moment it becomes an emergency. He nods. He says he has 3 apprentices at the bakery who cannot manage without him for more than a week. You tell him the recovery time for this surgery, properly conducted and properly managed, is approximately 3 weeks before he can return to moderate work and 6 weeks before he should return to heavy lifting. He closes his eyes. You watch him do the arithmetic. A baker who does not bake for 6 weeks loses 6 weeks of income and possibly customers who found another source in the interim. A baker who develops a strangulated hernia at the worst possible moment, when the emergency surgery is more complex and the recovery longer and the outcome less certain, loses more than that. The arithmetic is not complicated. He opens his eyes. He says, "All right." You write it in the record. When the evening round begins, Michael examines the baker and confirms the assessment and schedules the surgery for 2 days from now, the interval needed to ensure the man is adequately rested and fed before the procedure and to allow the preparation of materials. Michael explains the procedure to the baker with the same precision and economy he uses for everything, no more than is needed, no less. The baker listens. He does not ask many questions. He is the kind of person who, once he has decided a thing, does not benefit from more information about it. Michael notes the surgical schedule in the record and moves on. At Alexios's bed, Michael lifts the dressing himself. He examines the wound for a long time. Then he says that the wound is closing correctly. He says this is not guaranteed at this point. He says it is the direction things need to go, and they are going in it. He looks at you. He says the hourly checks were the right call. You say nothing. There is nothing to say. The checks were the right call because he told you to do them, and you did them, and the wound responded. Whether you would have known to do them without being told is a question that does not need to be asked right now. Maybe in a few years it will not need to be asked at all. The ward settles into evening. The light through the high windows goes gold and then orange and then the particular deep gray of dusk in a city that is too large to ever be fully dark. The glow of 100,000 lamps and fires reflected off the low clouds that have been building since afternoon. The smell of rain coming, the smell the city makes when the sea air moves inland and mixes with everything the city already smells of, smoke and bread and animals and salt water and stone, that has been in the sun all day and is releasing it now into the cooling air. Alexios is eating again. He eats more than yesterday. You count this as a victory of the small and specific kind, the kind this work runs on. You make your final note for the day and hand the ward to Euthemios. Tomorrow the baker's surgery preparation begins. Tomorrow Zoe's splint gets its first check. Tomorrow the monk's breathing will be what it will be. You walk out through the ward entrance into the corridor and toward the evening, and the hospital breathes around you, and the city breathes beyond it, and somewhere in all of that breathing there is, for now, enough. The rain comes overnight. You hear it on the roof of the staff quarters. The particular sound of rain on stone and clay tile, a sound that in Constantinople carries differently than in Anatolia because the city is so dense, so layered, that rain hitting one surface immediately finds another surface, and the sound multiplies until it becomes a kind of white noise, steady and encompassing, the sound of a city being washed. You sleep better than you have in several nights. The rain is still falling when the bells ring matins at midnight, the first of the night offices, and you surface briefly into wakefulness and hear the rain and the bells together and then go back under, and when the prime bells come at dawn you rise into a morning that smells of wet stone and clean air and the particular freshness that follows rain in a city by the sea, when everything that was in the air has been washed down into the streets and the streets are carrying it toward the harbor. You dress You carry your lamp to the surgical ward. At the ward entrance, you pause. Euthemios is already there, waiting for you, which is unusual. The handoff normally happens inside the ward, at the preparation table. The two of you standing with the record between you. He is standing outside, in the corridor, and his face has the look of someone who has been awake through something difficult and is now on the other side of it. You ask. He tells you the monk died at the 4th watch. He tells you Michael was notified and came to the ward and confirmed the death and gave instruction for the body to be prepared for the monastery's burial rites. He tells you the death was quiet, the breathing simply slowing over the course of perhaps an hour until it stopped. No distress that he could observe, no moment of crisis, just the gradual diminishment of a process that had been diminishing for days. He tells you the monk's name was Nicephorus. You did not know his name until now. This is not unusual. The patients in the surgical ward are referred to in the records by bed number and condition, and in conversation by their presenting complaint, or their name if you know it. And you know the names of the patients you have spoken with directly and not the names of the patients who have been asleep or unconscious or beyond the point of conversation during your contact with them. Nicephorus was beyond that point when you arrived. He was already in the stage where the body's engagement with the external world has begun to retract, the stage where the appropriate care is warmth and cleanliness and the management of pain and the presence of people who know what they are watching. You knew what you were watching. His name was Nicephorus. You go into the ward. The bed where he lay is already stripped, the linen removed and sent for laundering in the prescribed manner, the bed frame wiped with vinegar solution. The ward orderly is efficient. By the time the morning round happens, the bed will be made with clean linen, and there will be a new patient file begun for whoever occupies it next, because the hospital does not hold empty beds while people wait at the outer dispensary. You stand at the empty bed for a moment. The same moment you always stand. The acknowledgement, the person was here. Now they are not. The bed will be occupied again before the day is out. You move to Alexios. His eyes are open. He saw the death last night, or some portion of it, because the ward is one room, and the events of a ward at night do not stay in their corners. He watches you approach with an expression that has something in it you have not seen from him before. A quietness, a stillness that is different from the stillness of pain management. You lift his dressing. The wound is clean, cleaner than yesterday. The edges have approximated further. The sutures are holding exactly as they should be. The honey surface has the quality Michael calls good healing, the dry, amber-colored surface that means the tissue underneath is doing what tissue does when it is not fighting infection, building itself back toward wholeness one layer at a time. You tell him the wound is looking good. He nods. He asks about the monk, not by name because he did not know the name either. He asks about the man who was in the bed by the wall. You tell him the man died peacefully in the night. Alexios is quiet for a moment. Then he says that the man was a monk, and that a monk dying in a hospital on monastery grounds is perhaps the most fortunate way for a monk to die, surrounded by the prayers of his brothers and in the presence of God's house. You think about this. You do not know if it is true in the way that Alexios means it, the theological sense. the sense of proximity to the divine. You do know that the monk died in a clean bed, in a warm room, with adequate pain management, without the physical distress of advanced illness left entirely unaddressed. Whether that is fortunate compared to dying at home, in a cold room, in pain, without the poppy preparation, without the clean linen, you think the answer is probably yes. You replace the dressing. You tell Alexios his wound is doing the right things. He says he knows because you keep telling him, and after enough times of being told, he has started to believe it. The morning round brings Michael and the surgical schedule for the day. The baker's surgery is tomorrow. Today is preparation. Michael goes to the baker's bed and examines the hernia again. The standard pre-surgical assessment, confirming that the reducibility has not changed, that the tissue is healthy, that there are no new signs that would complicate the planned procedure. He speaks to the baker with the same economy he uses for everything, explaining what will happen tomorrow, what the preparation today involves, what the recovery will require. The baker listens. He has the quality of someone who has decided, which is different from the quality of someone who is still deciding. The decision has settled in him, and he is already past it, already in the space of what comes next. Michael assigns you the presurgical preparation. This means today you will spend time with the baker, explaining the procedure in more detail than Michael's summary, answering the questions that come when a patient has time to think about what they have been told, administering the preparatory regimen that the hospital uses before abdominal surgery, which involves dietary restriction and bowel preparation and the cleaning of the operative site, and checking that the materials for the surgery itself are ready, the instruments cleaned and prepared, the suture material selected, the honey and vinegar ready for post-operative wound care. You begin in the morning, after the round. The baker's name is Basil. You learn this when you sit at his bedside and introduce yourself as the one who will be handling his preparation today. He has the large hands of his trade, the forearms you noticed when he came in, and the slightly surprised quality of a person who expected to be handled impersonally and is finding that the institution is more attentive than expected. You explain the surgery again, in more detail than the admissions conversation allowed. You explain what the word hernia means in terms of the anatomy, using the drawings in Paul of Aegina as reference, holding the text open and pointing to the relevant illustration. Basil looks at the illustration with the focused attention of someone who thinks in physical terms, who understands things by understanding how they work mechanically, and you see the moment when the abstract information becomes real to him, when he understands not just that there is a weakness in his abdominal wall, but what that weakness looks like and what the surgery will do to address it. He asks if the weakness will come back. You tell him that a properly repaired hernia has a good chance of remaining repaired, but that the factors that produced the weakness in the first place, the years of heavy lifting, are still factors, and that after recovery he should be aware of this and manage the lifting accordingly. He thinks about this. He says his father had a hernia. You ask what happened to his father's hernia. He says his father did not do anything about it until it became an emergency, and that the emergency killed him, because by the time they brought his father to a physician, the tissue had already been without blood supply for too long, and there was nothing to be done. You are quiet. Basil says this is why, when the dispensary physician told him to come here, he came. He says he did not want to be his father. This is the thing that no medical text addresses and no training prepares you for. The moment when a patient tells you the private reason behind the public decision, the real story underneath the clinical presentation. You can learn about hernias from Paul of Aegina. You cannot learn from Paul of Aegina what Basil just told you. You tell him that coming here was the right decision. You mean it. The preparation takes most of the morning. The dietary restriction is already in place, ordered last night. The bowel preparation is administered mid-morning by the ward orderly under your instruction. The standard preparation used before abdominal procedures, unpleasant but necessary, and Basil endures it with the stoicism of a man who has spent his life in physical discomfort and has developed a relationship with discomfort that is not comfortable but is functional. While the preparation is proceeding, you check the surgical instruments. The instrument set for hernia repair is kept in the preparation room, the room between the ward and the dispensary where the tools of the surgical trade are stored and maintained. The instruments are made of bronze, some of the older ones, and iron, the newer ones, and one or two of the more expensive specialized instruments of polished steel that came from an instrument maker in the Armenian quarter who is the only craftsman in Constantinople producing surgical instruments of that quality. You check each instrument against the list Michael maintains, the checklist that specifies not just what instruments are needed, but their condition, because an instrument that is not sharp, not clean, not structurally sound, is an instrument that will fail at the worst possible moment, which is the moment of use. The bone saw is not in the set. You find it in the adjacent cabinet, where it was placed after cleaning following Alexios's surgery. You check its condition. The blade is intact. The teeth are clean. You add it to the set, because bone saw on a hernia repair is unusual but not impossible, because sometimes tissue exploration reveals more than the presurgical assessment anticipated, and you do not want to need a bone saw and not have it. Michael has taught you this without saying it in words. Always have what you might need. The afternoon brings a new admission from the outer dispensary. A child, 7 years old, brought by his mother, with a burn on his right hand from a cooking fire. The burn is deep on the palm and the base of 3 fingers. The kind of burn that happens when a child's hand moves faster than a child's understanding of fire, which is a constant in every ward that treats children, in every era, because fire and children occupy the same spaces, and children's understanding of consequences develops more slowly than their ability to reach. You admit the child. His name is Konstantinos. He is small for 7, dark-eyed, currently beyond crying, in the state that follows the acute phase of a bad burn, where the initial shock has passed and the pain has settled into a steady presence and the crying has exhausted itself, and what remains is a kind of dazed watchfulness. His mother is not in this state. His mother is in the state of acute fear that manifests as extreme stillness and very controlled speech, the stillness of a person who has decided that if she stays very still and speaks very carefully, nothing else will go wrong. You treat them both. You treat the burn with the standard protocol: cold water irrigation first, then the honey dressing, thyme honey. The same preparation used on Alexios's stump, applied liberally over the burned surface and covered with clean linen. The pain management for a child is a reduced dosage of the poppy preparation, adjusted for weight, a calculation you make carefully and check twice because the margin for error in a child is smaller than in an adult, and the consequences of miscalculation are less forgiving. You treat the mother by telling her, slowly and clearly, that the burn is serious but not life-threatening, that the hand will require careful management over the coming weeks, but that the fingers are intact, that the function of the hand is not determined yet, but that you have seen burns of this kind heal with good function when managed correctly, and this is your intention. She asks if he will be able to use his hand. This is the question parents always ask. It is the same question Zoe asked about her wrist. It is always about function, about what the person will be able to do, because people understand their lives in terms of what they can do, and the prospect of permanent limitation to that is a specific kind of loss that requires its own kind of addressing. You tell her you do not know yet with certainty. You tell her the burn is deep enough that the healing will take time and the final outcome of function will not be clear for several weeks. You tell her that the treatment you are beginning now is the best available and that the hospital will monitor him carefully and that you will tell her as soon as you know more. She nods. She does not look reassured, but she looks like someone who has received real information rather than a vague comfort, which is different, and sometimes different is what is needed. Konstantinos falls asleep while you are changing his dressing for the second time, the sleep of a child whose body has decided that the day has been enough and is proceeding to shut down regardless of circumstances. You finish the dressing around the sleeping hand with care, the care you take with the procedures you do on people who are not awake to tell you if you are causing pain. By the evening round the ward has 11 patients in 10 beds, because Konstantinos has been placed in the bed adjacent to the Tanners, the two of them sharing the space that is normally one patient's by the practical necessity of the situation, the ward full and the child needing to be admitted and the space being made. Michael does the evening round and sees the burn and the child and the adjusted bed arrangement and says nothing about any of it, which means it is what he would have done. He checks Alexios last, the way he has been checking Alexios last since the surgery. The deliberate final position that you understand means the wound is still the primary concern of the ward, still the case that requires the most careful watching, still the one that is not yet decided. He lifts the dressing. He looks for a long time. He replaces the dressing. He says the wound is healing. He says it as a statement, not a prediction, not a hope, but a description of what is currently happening in the tissue of Alexios's stump. The wound is healing. This is a different thing from the wound is doing well, which is provisional. The wound is healing is a declaration. You allow yourself, briefly, to feel the relief of it. Then you write it in the record. The evening meal comes. The ward settles. Outside the high windows, the rain has stopped and the air coming through is cold and clean and smells of the sea. And in the harbor, the Pantokrator is lit with the torches of the night watch. And somewhere in the Blackernay district, a dockworkers' family is sitting with whatever they have for dinner. And they do not yet know what you now know, which is that the man who works that dock is going to come home to them. You will know this more certainly tomorrow. But tonight it is true enough. Tonight it is enough. You hand the ward to Euthimios at the end of the evening round. He takes the record from you and reads through the day's notes with the focused attention he brings to everything, the attention you recognized in him from your first month working alongside him, the quality that will make him, eventually, a very good surgeon, the quality of wanting to understand everything thoroughly before acting on any of it. He asks about Konstantinos, the child with the burn. He asks about the dosing schedule and the dressing change interval, and the indicators that would require waking Michael in the night. You go through all of it. You go through it more carefully than the ward record requires, because euthemios on night call with a burned child is a situation that benefits from more information rather than less, and because you remember what it felt like in your first months to be on call overnight with a pediatric case, the anxiety of the smaller margins, the smaller body with its faster changes, and its different tolerances, and its inability sometimes to tell you what it is experiencing in the way an adult can. Konstantinos is asleep. His mother is sitting on a stool beside the bed. She has been there since the evening meal. The ward visiting rules specify afternoon hours, but the ward rules also specify that Michael has discretion in exceptional circumstances, and the presence of a 7-year-old in the ward with a serious burn qualifies as exceptional, and so the mother stays, and the ward works around her presence, and no one says anything about it because no one needs to. You tell Euthemios to let her stay through the night if she is quiet and not disruptive. He nods. He does not need to be told this, you realize. He would have made the same call. You are learning to trust his judgment the way Michael trusts yours, by watching it operate and observing that it is reliable. This is how the hospital propagates itself. The knowledge and the judgment moving from one generation of practitioners to the next, not through formal ceremony, but through the daily accumulation of small observations, small decisions, small moments of recognition between people who are all, in the end, trying to do the same thing. You take your lamp. You walk out through the ward entrance into the corridor that smells of rain and stone, and the faint residual smell of the dispensary, the herbs and the vinegar, and the preparations that are always being made and always in the air. Tomorrow is the baker's surgery. You stop in the corridor and think about this. Tomorrow you will assist Michael with the hernia repair, a procedure you have assisted once before, a procedure you know the steps of in the sequence they need to happen, a procedure that is not among the most complicated in the surgical repertoire, but is also not simple, because no surgery is simple, because the body is not simple, because the gap between what you know before you open a person and what you find when you do is always present and cannot be fully prepared for, only managed when it arrives. You have been managing gaps for 6 months. You are better at it than you were. You are not as good at it as you will need to be. These two things are both true, and they exist in you simultaneously without contradiction, because this is what the work teaches you if you pay attention. That competence is not a destination but a direction, that the distance between where you are and where you need to be does not close but reconfigures, the near problems becoming solvable and the far problems coming into focus, always more visible the further you travel toward them. Michael understands this. You think Anna understands this. You think Euthemios is beginning to understand it. You walk toward the library room. You want to read the hernia section in Paul of Aegina one more time before you sleep. Not because you do not know it, because reading it the night before the surgery will put it in the part of your mind that is most accessible in the morning, the part that does not require searching, that produces information the way a well-used tool comes to hand, without looking. The library is empty at this hour. You light the lamp on the library table from your own lamp, sit on the bench, pull the codex from its place on the shelf. The pages are worn at the hernia section in the way pages get worn when they are consulted frequently. the leather soft and slightly discolored at the edges from the oils of many hands, yours among them now, added to all the others going back to whenever this copy was made. You read. The ward sounds reach you faintly through the corridor, the low ambient sound of 11 people breathing, one of them a child, one of them a baker who has decided to stop being his father, one of them a dock worker whose wound is healing. Outside the city. Outside the city, the empire, extending east toward Anatolia, toward the place you came from, toward the mountains and the grain fields and the small town where your father still sets bones and lances abscesses by the knowledge he accumulated over decades without a typicon, without a library, without a hospital to work in, by the accumulated weight of what he saw and what he tried and what worked and what did not. You think of him sometimes, in the evenings. You will write to him when the baker's surgery is done. You will tell him about the hernia repair. He will understand what you are describing. He will not have all the words for it that you now have, the Greek technical vocabulary, the Latin borrowings, the Arabic terms that have entered the medical language through the translated texts, but he will understand the procedure itself, the logic of it, the reason it is done, and the way it is done, because the logic of surgery is older than its vocabulary and exists in the hands before it exists in the language. This is something your father knows. You close the codex. You return it to the shelf. You carry your lamp back to the staff quarters and lie down on the narrow pallet and listen to the city settling into its deepest nighttime quiet, the sounds diminishing until what remains is only the most essential, the harbor, the wind, the bells of the night offices from the monastery church above, regular and unhurried, marking the hours of a night that will end, as all nights end, in the smell of the ward and the lamp and the morning. Tomorrow, always tomorrow. You close your eyes. The surgery begins at the 4th hour. Michael arrives in the surgical ward at the 3rd hour, earlier than his usual time, and goes directly to the preparation room without speaking to anyone, which is how you know the surgery is on his mind the way it is on yours, occupying the front of the morning before the morning has properly begun. You are already in the preparation room. You have been there since the prime bells, checking the instrument set a second time, not because you expect to find something wrong, but because checking is the thing you can do, and doing something is better than standing in the ward thinking about the procedure. The instruments are laid out on the clean linen in the order of their use, the sequence Michael taught you during the one previous hernia repair you assisted, the order that allows each instrument to come to hand without searching, without the delay that in a surgical situation is a cost you cannot afford. Michael looks at the instrument layout. He moves one instrument, the curved needle for the deep sutures, from its position at the far right to a position closer to the center. He says nothing. You note the adjustment. Basil is brought to the surgical area at the 4th hour on the wheeled platform the hospital uses to move patients who should not walk, a practical device. 2 large wheels at the rear and a handle, the kind of thing that appears nowhere in the medical literature because no one has thought to write about it, but that exists in this hospital because someone, at some point in the 11 years of its operation, decided that rolling patients to surgery was better than walking them, and built the device, and it became part of how things are done. He is wearing the clean linen garment the hospital provides for surgical patients, loose, opening at the front, designed for access. His face is the face of the decided man, the man who has passed through the anxiety and come out the other side into a kind of flat calm, the calm that is not peace but is the state that follows the exhaustion of available alternatives. You tell him good morning. He says good morning in the voice of someone for whom good is not quite the word, but who is observing the social form anyway. Michael positions himself on Basil's right. You position yourself on the left. Euthemios stands at the patient's head, his role today being the management of the poppy preparation, the monitoring of Basil's state throughout the procedure, the voice that talks to Basil during the moments that require a voice. Michael makes the incision. It is a single clean motion, the kind of motion that contains 40 years inside it. The angle and the depth and the length all determined before the blade touches skin and executed without hesitation, because hesitation in an incision is worse than the incision itself, because a hesitant incision is a ragged incision, and a ragged incision is more difficult to close and more prone to complication. You have your hands where they need to be before he finishes. You know this because he does not tell you to move them. The dissection proceeds through the layers of the abdominal wall, the skin and the fatty tissue beneath it, and the fascial layers that are the structural elements of the wall, the layers that in a healthy person hold without thinking about it, and in Basil have developed a gap where the thinking stopped. Michael works with an economy that you are still learning to imitate, each movement serving a purpose, no movement repeated, the field of the surgery clear and organized and controlled. You control bleeding where it appears with the linen pledgets, the small squares of clean linen that absorb and compress, holding pressure on each small vessel until it stops, releasing, moving to the next. Michael locates the hernia sac. It is the size he assessed externally, approximately the size of a plum, the peritoneal membrane bulging through the gap in the fascial wall, the contents of the abdomen pressing against the membrane from inside. He palpates it carefully, determining the relationship between the sac and the surrounding tissue, the position of the vessels he must not damage, the boundaries of the repair. He begins the reduction. He reduces the contents of the sac back through the gap, carefully, with a patience that would surprise you if you had not watched him work before. Speed in this step is not the goal. The goal is complete reduction, without damage to the contents, without the tearing that would convert a controlled surgical situation into a different kind of situation entirely. The contents reduce. You hear Basil make a sound. Euthemios speaks to him, low and steady, the voice of someone who has been trained to keep another person's attention directed somewhere other than what is happening in their body. Basil is quiet. The repair proceeds. Michael closes the gap in the fascial wall with sutures, the technique described in Paul of Aegina and modified through Michael's own experience into something that is partly the text and partly 40 years of outcomes observed and adjustments made. The sutures are placed with the curved needle you noted in its new position, and now you understand why Michael moved it. Because the angle of approach he uses for the deep fascial layer requires the needle to be oriented in a way that is not immediately intuitive from the description in the text, a small adjustment of technique that must have come from practice and been so thoroughly integrated into his movement that he probably could not explain it in words, only demonstrate it. He demonstrates it now. You watch. You will remember this. The closure proceeds through the layers in reverse order of the opening. each layer closed before the next is addressed. The principle of layered closure that is both structural and infection resistant, because each closed layer is a barrier between the deeper work and the external environment. The skin is closed last. Michael ties the final suture and straightens. The entire procedure has taken just under an hour. You irrigate the wound surface with the vinegar solution, apply the honey dressing, cover it with clean linen. Basil is awake, or nearly awake, the poppy preparation wearing toward its edge. His color is acceptable. His breathing is regular. Euthemios checks his pulse and gives you a nod that means what it means. Basil asks if it is finished. You tell him it is finished. He closes his eyes. He does not speak for a moment. Then he says his father would not believe this. He says it quietly, to himself as much as to you, and you understand what he means by it, and you do not add anything to it because it does not need anything added. Basil's father died of a strangulated hernia because he did not come to a hospital. Basil's came to a hospital. The surgery is done. The repair is made. The outcome is not certain yet, because outcomes are never certain in the hours immediately following a procedure. But the direction is right, and the direction matters. You help move him back to his bed on the wheeled platform. Michael writes the operative notes. You stand at the preparation table, writing your own notes, the junior assistant's record of the procedure, what was done and in what order and what you observed, the kind of note that serves partly as a record and partly as a rehearsal, the act of writing it, consolidating what you saw into a form that you can access later, when the memory of the visual and the tactile begins to blur with time into a general impression rather than a specific sequence. You write the position of the curved needle. You write the way Michael's hands moved at the deep layer. You write the timing. Afterward, Michael comes to the preparation table and reads what you have written. He reads it for a long time. Then he says your notes are better than they were 3 months ago. This is the most direct thing he has said to you about your performance in 6 months. You say thank you. He nods and goes to see his next patient. The afternoon comes. Alexios is sitting up, not just propped against the rolled blanket, as he has been sitting for the past 2 days, but fully upright, his back straight, his legs extended on the bed in front of him. He has the look of a man who has decided to test something and found it does not hurt as much as he expected. You check the wound. The edges have approximated fully on the upper 3/4 of the wound. The lower quarter still has a small gap, the seepage site you have been monitoring, now nearly dry. The honey surface covers the entire wound in a continuous layer. There is no heat in the surrounding tissue, no redness, no discharge that indicates anything other than the ordinary progress of healing. You tell him the wound is closing. He asks how much longer. You tell him that is a question for Michael, but that the direction is right, and that right direction is what this stage of recovery requires. He says he wants to go home. You tell him you know. He says his youngest daughter is 4 years old, and she does not understand where he has gone. You tell him that in a city this size there are ways to send messages, that the ward can help arrange this, that it does not require his physical presence for his daughter to know that he is coming. He looks at you. He says he had not thought of that. You arrange it with the ward administrator that afternoon. A message carried by one of the monastery's lay workers who makes regular circuits through the city's districts on the hospital's various errands to Alexios's home in the Bluchernay district. The message is brief because Alexios is not a man accustomed to dictating letters, and the vocabulary for this kind of communication is not something he has practiced, but the message conveys what it needs to convey. That he is alive, that his wound is healing, that he will be home. You carry the message yourself to the ward administrator. This is not in the tipikon. It is in the space between what the tipikon specifies and what the situation requires, the space where, in 11 years of this hospital's operation, a particular kind of practical compassion has developed that is not quite medicine and not quite administration, but is the thing that makes both of them possible. By the 5th hour, Konstantinos is awake. He woke in the early afternoon, slowly, with the disorientation of a child who fell asleep in one context and woke in another, who expected to be in his own bed and found himself in a ward with stone walls and the smell of vinegar and 10 other people in various states of recovery. His mother was there when he woke, which was the most important thing, and he oriented to her presence the way young children orient, by fixing on it and using it as the reference point for everything else. He is still frightened. His hand is bandaged to the wrist, bulky with the honey dressing and the clean linen, and he holds it slightly away from his body, the way people hold injured parts, the unconscious protective gesture. You sit beside his bed. You are aware that sitting beside a child's bed in this ward requires a different approach than sitting beside an adult's bed, not in the substance of what you know or the care you take, but in the manner of the communication, the adjustment for the age, for the fact that a 7-year-old's understanding of what has happened to his hand and what will happen next is built from a different set of experiences and fears than an adult's. You ask him if he can tell you about his hand. Not what happened, which you already know, but what the hand feels like right now. Whether there is pain and where and what kind, the specific assessment questions that give you information about the wound's current state beneath the dressing. He thinks about this seriously, the way children think when they decide to take a question seriously. He says it feels hot. You tell him that is normal, that healing feels warm, that the warmth means his body is working on fixing the hand. He asks if his hand will be normal again. You tell him you hope so. You tell him that his hand is young and young hands heal well. You tell him that the treatment you are giving it is the best treatment the hospital knows how to give. He is quiet for a moment. Then he asks if you have seen a lot of burned hands. You tell him you have seen several. He asks if they got better. You tell him most of them did. He considers this. He says most is not all. You tell him he is right, and that most is what you can promise, and that most is better than not knowing. He nods with the gravity of a child who has decided to accept an answer that is not entirely satisfying because it is honest, and honesty is something children recognize, you have found, with more reliability than adults sometimes expect. You change his dressing before the evening round, the second dressing change of the day. The burn surface is what it needs to be at this stage, the honey layer intact, no sign of the progressive tissue death that would indicate the burn is deeper than your assessment, the skin at the edges of the burn beginning the process that will eventually be healing. the process that will take weeks and that you cannot speed, only support. His mother watches every step. You explain every step to her as you do it. She asks the right questions, the questions of someone who is paying close attention and intends to continue paying close attention. You understand from this that Konstantinos at home will be monitored as carefully as he is here, that the discharge instructions you give when the time comes will be followed, that the transition from the hospital's care to the home's care will be managed by someone capable of managing it. This matters. Half the work of treatment happens outside this ward, in the ordinary spaces of ordinary life, where the patient and their family carry forward what the hospital began. The evening round brings Michael to each bed in sequence. At Basil's bed, he lifts the operative dressing and examines the wound. The wound is clean, the sutures are holding. The surrounding tissue shows the normal inflammatory response of a healing wound, and nothing beyond it. He replaces the dressing without expression and makes a note. At Konstantinos's bed, he examines the burn with the same attention he gives to everything, assessing the depth, the extent, the condition of the tissue at the wound margins. He asks Konstantinos to move his fingers. Konstantinos moves them, carefully, the 3 fingers that are bandaged together with the 2 that are free, a small tentative motion that tells you the tendons are intact and the deep structures of the hand are functioning. Michael says, "Good." He says it to Konstantinos directly, not to you, not to his mother. Konstantinos looks at him. Michael says the hand is working, and that working is what they need it to do. Then he moves on. You stand for a moment at the foot of Konstantinos's bed and watch the child watch the surgeon walk away. The look on his face of someone who has just been told something important by someone who clearly knows important things. His mother looks at you. You nod. She nods. This is how things are communicated when all the words have been used, and what remains is simply the fact, the ward in the evening, the work done, the patients present, the direction right. You make your final notes for the day. You hand the ward to Euthemios with the care of someone who understands what they are handing over. You walk out into the corridor. The city is out there, doing what it always does. 400,000 lives moving through their evening, eating and arguing and working and praying and sleeping and failing and managing, the enormous ordinary motion of a city at the edge of an empire that is still tonight holding. You are part of that. You are a small part of it. A 22-year-old in a stone corridor smelling of vinegar and honey and rain, carrying a lamp toward a narrow bed where you will sleep and wake and come back. You will come back tomorrow. You will always come back tomorrow, until the day you do not, and between now and that day there is all of this. All of this is enough. You stop at the library room on your way to the staff quarters. Not to read tonight. You are too tired to read. The particular tiredness that follows a surgical day, the weight of sustained attention finally releasing. You stop because you want to check one thing, a small, specific thing that the day has raised in your mind and that you want to verify before you sleep, so it does not sit at the edge of your thoughts the way unresolved questions sit when you lie down. The question is about wound closure after fascial repair. Paul of Aegina describes 2 approaches to closing the fascial layer after hernia reduction. The first is the interrupted suture. individual knots placed at intervals. The second is the continuous suture running the length of the repair. Michael used the continuous suture today, his preferred technique, the technique you have now seen in practice. Paul favors the interrupted suture on the grounds that failure of a single interrupted suture does not compromise the others, whereas a continuous suture that fails at one point creates a cascade. You find the page. You read it. Paul's reasoning is sound. The mechanical logic of distributed versus continuous closure is real. But Paul is working from principle, from the structural theory of closure, and Michael is working from 40 years of outcomes, from the accumulated evidence of what he has seen actually happen in the bodies of actual patients. These two things do not contradict each other. They are different kinds of knowledge, and the distance between them is not a flaw in either but the space that medicine occupies, the space between what theory predicts and what bodies do. You close the codex. You sit for a moment. This question will not be resolved tonight. It may not be resolved in your working lifetime, or in any working lifetime available to you in this century, because the resolution would require the kind of systematic comparison of outcomes that does not yet exist anywhere in the world as a formal method, accounting and categorizing of results across enough cases to determine which approach produces better outcomes and under what circumstances and for what kinds of patients. You understand, sitting in this library room in 1136, that this is a question someone will eventually answer. You also understand that the answer is probably not simple, that the answer is probably something like it depends, which is the answer to most questions in medicine when they are asked carefully enough. You replace the codex. You stand. You have been in this city for 4 years. You have been in this hospital for 3 of them. You have learned more in this building than you learned in all the years before it. And you are still in the early stages of what this building can teach you, still reading texts that were written centuries ago, and finding in them things you did not understand the first time you read them. Things you understand now because the practice has given you a different eye. Your father in Anatolia learned by doing. You are learning by doing, and by reading, and by watching, and by asking questions that cannot currently be answered, which is a different kind of education, slower in some ways and faster in others, and you are not sure yet which kind produces the better physician. Possibly both are necessary. Possibly the physician who only does and the physician who only reads are both limited in ways the physician who does both is not. You take your lamp. You walk down the corridor. The monastery is in its nighttime state, the great silence that follows Compline, the quiet that the monastic rule imposes on the hours between the last office and the first office of the new day, the silence that the hospital exists within but is not entirely bound by, because the hospital runs through the night, and night requires some sound, the low talk of the staff on duty, the sounds of patients, the small, necessary noises of a ward that does not stop. From the surgical ward you hear, distantly, Euthemios's voice. It is low, steady, the quality of voice used for night rounds, not clinical efficiency but something quieter, the voice you use when the ward is asleep and you are moving through it, and you want to disturb as little as possible of the fragile equilibrium that sleep gives these people who need it. Konstantinos is probably still awake, you think. 7-year-olds in unfamiliar places do not always sleep easily. You think about going back to check. Then you decide against it. Euthemios is there. The ward is in capable hands. The temptation to return to the ward when you are not on duty is a temptation you have been learning to resist, because the physician who cannot leave the ward cannot sustain themselves across the length of a career, and sustaining yourself across the length of a career is something this work requires. Michael leaves the ward. Michael sleeps. Michael returns the next morning and does it again, and has done it again for 9 years, and will do it again for however many years remain to him, and the doing of it again is possible because the leaving of it was also done. You continue toward the staff quarters. The rain has not returned, but the air still carries it. The memory of last night's rain in the smell of the stones, and the particular weight of the air that comes off the Bosphorus when the weather has been through. You can smell the sea beneath everything else, beneath the city smells, beneath the hospital smells, the great salt presence of the strait that runs past the city's eastern edge and connects the Black Sea to the Marmara, and beyond it to everything else. Constantinople sits at the center of the world as the world is understood in 1136. East of it is Asia, the Islamic caliphates, the Silk Road, the cities of Persia and Mesopotamia, and further, India and China at the edges of the knowable. West of it is the Latin world, the patchwork of kingdoms and principalities, and the Church of Rome, the world that sends crusaders through this city on their way to Jerusalem, the world that looks at Constantinople with a mixture of awe and resentment that you have observed in the faces of the Latins who pass through, the awareness that what they are seeing here, this city, this civilization, this hospital, is older and larger and more sophisticated than what they come from. You do not think about this with pride. You did not build this city. You came to it. You think about it with the particular gratitude of someone who arrived in a place and found that the place was more than they expected, and has continued to be more than expected with each year of proximity to it. Your pallet is narrow, and the blanket is coarse, and the window faces east, so you will wake with the first light, whether the bells ring or not. You lie down. You think for a moment about the curved needle and its position on the preparation table. Then you stop thinking and let the night have the rest of it. Tomorrow you will wake before the bells. Tomorrow the ward will smell the way it always smells. Tomorrow Basil's wound will want checking, and Konstantinos's dressing will want changing, and Alexios will ask how much longer, and you will tell him the wound is doing the right things because it will be. Tomorrow will be tomorrow, complete in itself, asking what it asks, giving what it gives. Tonight there is only this. The city outside, breathing. The ward, breathing. You in the narrow space between them, also breathing, also present, also here. Sleep comes the way it always comes in this place, not slowly, not with ceremony, just the gradual diminishment of the foreground, until only the background remains, the sea and the bells and the stone and the ward, and then even those recede, and there is nothing, and then morning. 3 days after the surgery, Alexios goes home. The discharge happens at the 2nd hour, after the morning round, after Michael examines the wound one final time and determines that the remaining open quarter has closed sufficiently to complete the transition from hospital care to home care. Michael gives the discharge instructions himself, standing at Alexios's bedside with the record open, going through the wound care protocol, the honey dressing that his wife will need to apply and how often, the signs that would require him to return, the activity restrictions for the next 4 weeks, the gradual return to work that is possible only after the wound has been fully closed for a minimum of 2 weeks, the hard limit of 6 weeks before anything involving significant use of his remaining leg. Alexios listens. He asks the right questions, the questions of someone who has been thinking about this conversation for days, who has been lying in this bed preparing for it the way you prepare for a surgical procedure, by going through it in advance and identifying the points you are uncertain about. He asks about work. Michael tells him the same thing you told him earlier, that the timing depends on the wound and the function of the remaining leg, that a dock worker without a full leg requires adaptations that will need to be assessed, that this is a conversation for after the healing is complete. Alexios nods. He understands that the conversation about his working life is a different conversation from the conversation about his wound, and that the wound has to be finished before the working life can be addressed. And he is, in some sense, at peace with this sequencing in a way he was not when he arrived. The hospital provides transportation for patients who cannot walk the distance home, a cart and a driver available through the monastery's lay staff for the morning discharge hours. Alexios uses this. He is helped to the cart with the assistance of the ward orderly and the crutch that the hospital's carpenter made to his measurements 3 days ago. A single crutch for the right side, the side of the intact leg, which allows a gait that is slow and requires concentration but is functional. Is movement, is the beginning of the return. You walk with him to the cart. This is not required. It is the kind of thing that exists in the space between what is required and what the situation asks for, and you have learned to read that space. At the cart, he turns and looks at you. He says he does not know how to say what he wants to say. You tell him he does not need to say it. He says he wants to anyway. He says that when he came here, he thought he was going to die. He says he lay in the bed the first night after the surgery, and he was certain, with the certainty of a man who has seen other men die from the same process in the same way, that he was not going to see his children again. He says he was wrong. He says you told him his body was working, and he did not believe you. And then gradually he did believe you, and then it was true. You stand in the morning light at the cart. You tell him that his body did the work. You tell him you watched it do the work, and you supported it where you could and cleared the path where you could, and the rest was the body. He looks at you. He says thank you. He says it the way people say things they mean and have been carrying for a while and are finally releasing. Then he is in the cart and the driver is moving and the cart is going down the monastery road toward the city, and you watch it go until it rounds the corner by the outer gate and is gone, and then you stand for a moment in the space it occupied and feel what you feel, which is something you do not have a precise name for, something between relief and satisfaction, and the kind of tiredness that is not the tiredness of exertion, but the tiredness of having been present for something that mattered. Then you go back to the ward. The ward does not stop. This is the truth of it. The ward does not stop for the discharge of a patient, or the death of a patient, or the moment at the cart. It continues, always continues, because the city continues, because bodies continue to do what bodies do in a city of 400,000 people. and what they do produces more need than this hospital can fully meet. More need than any hospital anywhere in this world can fully meet. And so the meeting of it goes on, one patient at a time, one wound at a time, one decision at a time. You meet it. Basil's wound, 4 days after the surgery, is doing what Alexios's wound did at this stage, which is to say it is closing, the repair is holding, the sutures are intact. The surrounding tissue has passed through the acute inflammatory phase and is in the longer, quieter phase of remodeling, the phase that takes weeks and is invisible from the outside except by the surface signs, the wound edges approximating, the suture line becoming less prominent, the tissue gradually returning to the quality of tissue that is not freshly operated on. Basil is not peaceful about his recovery, the way Alexios eventually became peaceful. Basil is impatient. He asks every morning how much longer. He asks about his apprentices. He asks whether the restriction on lifting applies to lifting bread dough, which is, he explains, a different kind of lifting from the lifting you are worried about, a gentler motion, a motion the body does differently. You tell him it does apply. He considers various arguments for why it should not. You listen to the arguments with the patience you have developed for this particular kind of conversation, the conversation with a patient who knows their own body well and is applying that knowledge to resist a medical instruction that inconveniences them. The arguments are always inventive. They are always wrong in the specific ways that matter. You decline them with the same steadiness each time, because steadiness is what the conversation requires, and eventually, usually, the patient arrives at the same place Basil arrives at on the 5th morning, which is an acceptance that sounds slightly like a complaint, but is functionally an acceptance. He says fine. He says he will tell his wife to manage the bakery. You tell him his wife is capable of managing the bakery. He says she is more than capable, which is why he has always been slightly frightened of her, which is said with the tone of a man who is not frightened of his wife at all, and is using the word frightened to express something closer to respect and gratitude that he has not found a different word for. You tell him that sounds like a good arrangement. He laughs. It is the first time you have heard him laugh. Constantinus's hand is healing. The burned surface at 1 week is showing the signs that indicate the healing is proceeding correctly. The new epithelial tissue growing in from the wound margins, the pink and red color of early regeneration, the decrease in the wound's exudate that indicates the inflammatory phase is concluding. His range of motion in the 3 affected fingers is limited, which you expected and told his mother to expect, and which will improve over the coming weeks as the healing tissue matures and softens. He is less frightened than he was. Children acclimate, you have observed, faster than adults in some respects and more slowly in others. The fear of the initial injury and the unfamiliar ward has diminished. The boredom of recovery has replaced it. The boredom of a 7-year-old who cannot run or play and must sit while his hand heals, which is its own kind of suffering. Not the suffering of the burn, but the suffering of the restriction, the constraint placed on a body designed for movement. His mother brings him things. Small things, the things parents bring to children in hospital when they cannot bring the thing the child actually needs, which is to be well and at home. A wooden toy, a piece of bread with honey from their own kitchen. A story told quietly at the bedside in the evenings. her voice carrying just far enough that you can sometimes hear the shape of it from across the ward without making out the words. You do not tell her to stop. The ward rules say nothing about stories. On the 6th day after the surgery, you find Michael in the preparation room at an unusual hour, the middle of the afternoon, a time he is normally in the other ward or the consultation room or the administrator's office. He is standing at the preparation table with a codex open, not reading it, just standing with it open and looking at something you cannot see from the doorway. You knock at the doorframe. He looks up. He tells you to come in. He tells you he has been thinking about the hernia repair. You wait. He says he has been thinking about the continuous suture versus the interrupted suture. He says Paul of Aegine's preference for the interrupted method has always been known to him, and that his own preference for the continuous method is based on experience, on the outcomes he has observed over 40 years, and that he has been reconsidering whether his experience is large enough to be confident in that preference, or whether Paul's mechanical reasoning should be given more weight. You say nothing. He looks at you. He says you have been reading the same section. You tell him you read it the night before the surgery. He says he knows. He says he could tell from your notes, which referred to the fascial layer in language that comes directly from Paul's description of the hernia anatomy. He asks what you thought. You tell him what you thought, the same thing you thought in the library that night. That Paul's mechanical reasoning is sound, but that it is reasoning from principle rather than from observed outcomes, and that principle and outcome are different kinds of evidence, and that both deserve weight. He is quiet for a moment. Then he says that is a careful answer. He says careful answers are what this work produces when it is done honestly. Because the questions this work raises are almost always questions that careful answers are the right size for. He closes the codex. He says that when you have been here long enough to have 40 years of your own observations, you should compare them with Paul's reasoning and see what you find. He says this as though it is a simple suggestion, a practical recommendation. The kind of advice a senior physician gives a junior one. You understand that it is also something else. It is 40 years away. It is a life of this work, a life of wards and records and patients and questions that cannot currently be answered, a life that ends somewhere in this corridor or one like it, in a hospital that may or may not still be this hospital, in a city that may or may not still be this city, because Constantinople in 1136 is not guaranteed to be Constantinople in 1176, and the things you cannot predict about the future of this city include things that will, in the decades to come, change it entirely. But that is later. That is always later. Right now, there is a man named Michael in a preparation room with an open codex and 40 years of outcomes and a question he is still asking. And there is you, 22 years old, with 6 months of outcomes and a question you started asking this week. You are both asking the same question. This is what the work is. The question is always open. The work is always going on. In the days that follow, the ward turns over in the way wards turn over, the rhythm of admission and treatment and discharge and death that is the rhythm of any hospital in any era, patients arriving with what their bodies have brought them and leaving with what the hospital was able to give them, which is sometimes a great deal and sometimes very little. and sometimes everything, and sometimes nothing at all. Zoe's wrist, at 2 weeks, shows good alignment on palpation. The splint is removed and replaced with a lighter support. She moves her fingers on instruction, the careful experimental motions of a healing joint testing its range. And the range is there, limited at the extremes but present, the function returning with the steady patience of tissue that is doing what it is designed to do. She thanks you before she leaves. She does not say what she is thanking you for, which is either the reduction or the 3 attempts or the fact that you told her the hardest part was over, or all of these things together, and you do not ask for clarification because the gratitude does not require it. Konstantinos is discharged at the end of the 2nd week. His mother carries him for the first part of the walk home, though he is 7 and protests that he can walk, and she carries him anyway, and he lets her, because he is 7 and still in the range where being carried by your mother is something you protest and then accept, and the accepting is a kind of pleasure that you will not have available to you for much longer. And some part of him knows this, even if he does not have the words for it. You watch them go from the ward entrance. The ward is quieter after they leave. It is always quieter after a child leaves. The day continues. Basil is discharged at the beginning of the 3rd week, walking on his own, his gait careful and slightly guarded, the gait of a man who has been instructed not to strain the repair and is honoring the instruction not because he is told to, but because he understands why, because you sat at his bedside and explained it to him, and he is a man who acts on things he understands. At the gate he turns. He says he will send bread when he is back at the bakery. You tell him there is no need. He says he knows there is no need. He sends it anyway. 3 weeks later, a large loaf carried by one of his apprentices to the hospital gate, with a note that says the apprentice's name, and that the loaf is from the baker in the Blackernay district who was afraid and is not afraid anymore. The ward orderly brings the bread to the preparation room. You share it with Euthemios. You eat it standing at the preparation table in the afternoon, between the morning round and the evening round, in the small interval of ordinary time that the work allows. It is good bread. It is the bread of a man who knows how to make bread, who has been making bread for 30 years in the same ovens with the same hands, who will make bread for as long as his body allows, which is now, because of a surgery in this ward, longer than it would otherwise have been. You eat the bread, and you think about this, and then you stop thinking about it, because the ward is still going, and there are patients who need the afternoon check, and the bread is finished, and the afternoon is what it is, another afternoon in a place that does not stop, in a city that does not stop, in a body of knowledge that does not stop accumulating, one patient at a time, one question at a time, one day at a time. You put down the bread. You go back to the ward. The high windows are letting in the late afternoon light, the long slanted light of the hours before vespers, the light that makes the ward look different from how it looks in the hard clarity of midday, softer, the stone walls carrying the gold of it, the beds casting long shadows, the patients in the particular stillness of the late afternoon, some sleeping, some in the near sleep that recovery produces, some simply lying in the light with their eyes open and their attention turned somewhere interior. This is the ward at rest. This is what all the work produces, this particular quality of afternoon. The ward functioning, the patients present, the treatments proceeding, the direction right. You stand at the ward entrance and look at it. Outside, the city. The harbor with its ships, the markets with their noise, the 400,000 lives in their ordinary motion, doing what they do, not thinking about this ward, not thinking about the question of continuous versus interrupted suture, not thinking about hernia repair or wound closure, or the slow accumulation of medical knowledge that moves forward so slowly it is almost invisible. One generation of physicians handing to the next a slightly better understanding of what the body is, and what it needs, and what can be done when it fails. They do not think about it because they do not need to. You think about it for them. This is what you are for. This is the work. You let out a long breath. The afternoon light moves slightly as the sun continues its arc, the shadows in the ward shifting a degree, the gold deepening toward the amber of approaching dusk, and somewhere in the monastery above you the vespers bells are beginning, the steady, reliable sound of the hours being marked, time being acknowledged, the day moving through its stages toward the night. You let the sound of it reach you. Let it carry the afternoon with it. Let the ward settle into its evening rhythm, the quiet settling, the peace that comes at the end of a day in which the direction was right, and the work was done, and the patients are still here, still breathing, still moving through their recoveries in the slow, patient way that healing requires. Let your breath slow. Let your hands be still. You have been here today. Tomorrow you will be here again. For now, for this moment, let the ward be what it is. Let the bells be what they are. Let the city go on outside in the gathering dusk, enormous and indifferent and alive, full of people who will need this place eventually, who will come to the outer gate eventually, who will lie in these beds and look at the high windows and ask whether their body is working, and you will tell them what Michael told you, what you have learned to mean when you say it. The body is working. That is what you need it to do. That is enough. The bells continue. The ward breathes. You have been in this hospital for 6 months, and in this city for 4 years, and in this work for as long as you can remember, and the work has shaped you the way all sustained practice shapes the person doing it. From the outside in, the hands first, and then the eyes, and then the way you think about the thing you are looking at. The reorganization of perception that comes from looking at the same category of thing long enough that you begin to see it differently, begin to see the structure beneath the surface, the logic beneath the presentation, the pattern that connects this patient to the patient before and the patient before that. You are not yet good at this. You are better than you were. You will be better than you are. This is the only direction available to you, and you are moving in it, and the movement is enough, not because enough is a consolation, but because enough is accurate, because the distance between where you are and where you need to be is not a failure but a map, and maps are not things to be ashamed of. They are things to be used. Michael uses a map. Michael has been using the same map for 40 years, and it has taken him somewhere, to this ward, to this knowledge, to the particular quality of hands that can place a curved needle in exactly the right position without being told. You have been using the map for 6 months. The map is the same map. You are on it. The ward settles further into its evening quiet. The patients slipping one by one into sleep or near sleep, the sounds of the afternoon giving way to the sounds of the night, the quieter register of a ward in the dark, the breathing and the small shifts of weight and the occasional low sound that is not distress but is the body working on something in the language bodies use when the mind has stepped back far enough to let them work without interference. Let the ward work. Let the bodies work. Let the night come in through the high windows and settle over the beds and the clean linen and the honey dressings and the splinted limbs and all the careful repairs that are in this moment holding. Let your breath find the rhythm of the room. Slower and slower still. The city is out there, turning. The ward is here. Still. You are here, in the still place, between the turning and the stillness, which is where you have always been, which is where this work puts you and keeps you and asks you to remain. Remain. The light fades. Sleep well. If this story found its way into your night and gave you something to rest with, a like and a subscribe help this channel more than you know. Thank you for being here. Good night.